All right, so welcome everyone to today's I Am Independence Amplified Maryland presentation brought to you by the Maryland Centers for Independent Living. Just a few announcements before we get started. We are going to be, since we're entering into legislative session, the Maryland legislative session, we will be carving out some time for people who have issues that they want to bring forth and discuss. You will have 5 minutes to do so, so just let us know. It'd be great to let us know ahead of time that you'd like to do this so we can make sure we don't have too many people. And 5-minute time limit, which Mike pointed out is really good because that will help get you ready to testify. You get a little less time than that, but it's good practice nonetheless. Also, our sessions are going to be extended a bit so our sessions are going to be every Monday, except for next Monday we won't have one, beginning at 2 and going until 3:15, so just by 15 more minutes more. I am so excited to have Sheryl Grossman here with us today. She is going to be talking about an issue that I know I have been working on behalf of the Maryland Centers for Independent Living for the past several years, and it is the physician-assisted suicide legislation. So this is a piece of legislation that keeps coming up every year, and this year is, we expect, I don't know if it's been dropped yet, but we expect it to drop any day now. And so Sheryl's going to kind of clue us in on what the legislation is, what it does, what it doesn't do, and why it is ableist in thought and idea, and would, be potentially impactful in a negative way should it pass. So I am going to share my screen and then turn it over. Hey, Sheryl, whenever you're ready.
Great. Thank you, Katie. So this is Sheryl. And a couple of notes, one for the captioner or interpreter if they're on today. If I'm speaking too fast, please speak up. I have a bad habit of doing that. And also as an accommodation note, I use things in text-only format. So I am not able to manipulate the screen in any way on Zoom. It is not accessible to me, nor is PowerPoint. So Katie's going to be helping me with slides, but also note that if you're typing in the chat or if you're raising your hand, I'm not able to acknowledge that because I can't interact with it. So if you can hold questions till the end, I promise to answer questions. It just makes it easier for me as I've memorized what's on the screen. So if I get off track, sorry about that. So without further ado, today we're going to talk about physician-assisted suicide. And for people with disabilities, that's really the battle for personhood. I'm doing this as board chair for an organization called Yada Chazaka, which is the Jewish Disability Empowerment Center. It's based out of New York, but we work nationally. And it's basically a center for independent living based on Jewish law as opposed to the Americans with Disabilities Act. So I can tell you about that at another time. If we can go ahead and advance the slide here. So let's start first with the definition of physician-assisted suicide. According to Merriam-Webster's dictionary, this is suicide by a patient facilitated by means like a drug prescription, or by information such as a medical provider giving you the information about a lethal dosage, a deadly dose that's provided by the physician who is aware of the patient's intent to harm themselves. Go ahead. The importance of this issue within the disability community here in Maryland is that this proposed legislation will go forward in the 2021 session. Like it has in many years previous. And for the second year in a row, we're up against a major lobbying group nationally, Compassion and Choices, which used to be called the Hemlock Society, hemlock being a poison, that has granted Maryland this session $1.2 million to lobby in favor of this. Go ahead, Katie. So what is the purpose of this particular bill? The purpose is to make it legal for a doctor, or to decriminalize the process for a doctor to prescribe someone a lethal medication, and also to protect that doctor from liability in case someone claims, hey, my family member or my friend didn't really want to do this and you coerced them or didn't understand what was happening. It protects that doctor from liability. The purpose of the bill also is to standardize the cause of death on the death certificate. So typically when a doctor signs a death certificate, they're signing on how the person died, the cause of death. Well, under this bill, it would require that that line be filled out by the doctor regarding what the underlying condition was. Heart attack, multiple sclerosis, asthma attack, diabetes, whatever that might be. Go ahead, Katie. So what this bill does not do, it does not change the status of a person's choice. The person themselves is not the focus of the bill. The focus of the bill is on what is legal for the doctor to do or not to do. What it does not do is also require crisis intervention or any other mental health service for a person with a disability who's stating that they want to harm themselves. What this bill does not do also is allow for data collection and tracking, because we don't even know, what the real reason for the person asking for this is. Also, excuse me, what the bill does not do, it does not provide for tracking or for the take back or disposal of a lethal prescription, lethal medication, once that prescription has been filled. And we've seen in other states where it's been the case where the person has died before taking the prescription and no one knows what happened to the medications. And that's a lethal prescription. Go ahead, Katie. So a lot of the folks who want this bill to go forward say that there are safeguards put into this bill to make it possible that no one with a disability is going to be abused or neglected or coerced into a decision unnecessarily, that this is specifically targeting a specific subset of people who want to end their lives in this way, and that these safeguards should protect people with disabilities. So I want to point out the myths and the facts about this. The first myth is that only people with a quote unquote terminal diagnosis can get this prescription. The fact of this is that it is very difficult for a doctor to medically accurately determine that someone is terminal. And under this bill, that meaning having 6 months or less to live. And I can go into this a little bit more depending on how much time we have towards the end. But I just want to stick in here now. I got into this fight because for me, my doctors were told I wouldn't live past 2, and I just turned 45. So there's a lot that is art about this. Doctors don't know everything about diagnosis, and there's a lot of wiggle room in here. So the definition of terminal is problematic. The second fact with this is that the definition of terminal for us, it includes far more people with disabilities than people realize. Things like diabetes, cancer, heart conditions, epilepsy, asthma. If you take a medication for a condition that may rise to the level of disability, and if you don't have that medication, that could jeopardize your life, like having an inhaler when you're having an asthma attack, having your heart medication within a day or two of when you're supposed to have it, diabetes, having insulin when you need it. If that can jeopardize your life within a 6-month period, you fit the definition of terminal under this particular bill. And that has always been problematic. Go ahead, Katie. So the context of this for people with disabilities is that people with serious illnesses and terminal conditions are people with disabilities, as we know. And so the slide that you have in front of you is a diagram. There's a large oval that says people with disabilities, and there's a small circle within that oval that describes people with terminal conditions. So federally, a person with a disability is someone that has a condition that's called an impairment in this bill that limits the person in one or more major life activity, has a history of that, or sees themselves or someone else sees them as having that condition, which relates more to discrimination. We can talk about that in health disparities a little bit later. So if you think about the person with the terminal condition that this bill is targeting, if the doctor believes that you are in a condition, a state, where you are being limited in your ability to sustain life, to stay alive more than 6 months, that meets that definition. So while not every person who has a disability is terminal, almost every person, not 100%, but almost every person with a terminal condition would likely fit into that category. Katie, if you could advance that, please. Thank you. Okay, so some further safeguards here. The myth of the person must consult a doctor before the medication can be prescribed. The fact with this bill is that when you go to a doctor, you're going to a doctor to fix something that is broken. That's their job. That's what they do. They diagnose something that is wrong to try to treat or cure it. So yes, you have to go to a doctor, but that doctor is going to be telling you what is wrong with you. If you're already predisposed to feeling badly about what is not working for you, this can actually make that worse, right? The second fact of this is that you can doctor shop. If you go to your doctor and your doctor wants you to talk to people at a Center for Independent Living or a mental health professional or a suicide crisis intervention hotline before prescribing a medication like this, if they say no and you still want this, you can go to any other doctor that you want and try to get it from them. There's no reporting by the doctor, so there's nothing on file like there is when someone shops around for an opioid, for example. There's no data bank to show that you already asked someone for this. And it's really important to note that Compassion & Choices advertises that they have a data bank of doctors ready, willing, and able to prescribe you this if you can't get it in another way. Go ahead, Katie. Okay, so another myth of this bill is that you have to have a psychiatric assessment prior to getting this prescription. The fact in this bill is that there is an assessment, but the point of the assessment is to determine if the person asking for the prescription understands what the medication will do and what the consequences of taking the medication will be. So if they ask you, do you understand that you will die if you take this medication, they're fulfilling that assessment. If you can answer that, you have done what they've asked you to do. But that's very different than getting psychological services to help you adjust to a life situation. So that's problematic for someone who's making a decision without having all of the resources in front of them. The fact of this is that this psychiatric assessment is a very poor replacement for independent living services. The Centers for Independent Living exist to help people adjust successfully to disability. And when you have a life-altering diagnosis, if you don't have all of the supports in front of you, if you don't have all of the information in front of you, if you don't know how the bigger picture might look, that can change your viewpoint, that can sway your decision making in a way that may not have the full picture. And so this can also be problematic. Katie, go ahead. This is an important one, a myth that the medication has to be self-administered. So a lot of doctors rely on this, that, hey, nobody can be abused by this if they're not able to take the medication themselves, because they have to actually do the action of self-administering it. Well, the fact of this is that if you have an attendant, whether it's a family member, paid provider, if they're doing food preparation for you and they hand you the food that you put in your mouth, or even if they help it to your mouth when you say so, that is considered self-administered. So let's say you take medication by having pills crushed into your juice, and your attendant takes the juice out of the fridge, puts it in your cup, crushes the medication, puts it in your drink and puts the straw in, and you do your drinking. Who's to say that you know exactly what has been crushed into that drink? Who's to say that that caregiver can't coerce that or can't abuse you in some way by doing it? So this is a big problem, a big hole in this bill. Another fact of this is, I don't know about you, but for me during COVID, I don't leave my house. I haven't left my house since last February. So all of my medications are delivered to me, or someone else goes and picks that up for me. That means that I don't have custody of those meds. I don't know exactly what's being handled. So that prescription, this prescription also could be picked up by someone other than the person with a disability. This is meant to help the person with a disability because it allows an attendant or a family member or a friend to pick it up for you. But what happens when that person does not have your best interest at heart? Again, we've mentioned this before, there's no regulations around the tracking or the disposal of these meds either. Go ahead, Katie. So another myth here is that having a one-on-one conversation with a physician will prevent abuse by a family member, because you have to have that conversation without the family member present. The facts, as we've said before, is that doctors are there to fix the person. And when fixing isn't possible, the way to avoid feeling guilty for not being able to fix the person is to, quote unquote, not have that brokenness in front of them. So, you know, the doctor can easily fall into this. It would be better if the person just took this prescription. So the facts here is that, you know, there's nothing to prevent someone else from picking up the prescription. There's nothing to prevent another person from handing the meds to the person in a way that they take it. And there's nothing to prevent the physician from coercing that decision. And I'm seeing that we're running slightly short on time. So on the slide, you'll see this is where I was going to tell my story. I'm going to hold that till the end if we have time. So go ahead, Katie, flip that. So let's talk about abuse, neglect, and coercion for just a second. On this slide, I have, this is actually a link to a newspaper article, but within the article is the actual study. In 2013, there was a study that came out publicly that showed that 7 out of every 10 people with disabilities, self-reported, report some form of abuse. So when we're talking about a population that is as highly vulnerable to abuse as people with disabilities are, this becomes a bigger deal. Katie, go ahead. So let's talk for a moment about the top 5 reasons that people request physician-assisted suicide, because this comes up a lot in terms of, well, you know, if people have pain or are suffering, shouldn't they be allowed to do this? So let's look at the data. Go ahead, Katie. And this is coming from a report from Oregon. Oregon has a Death with Dignity Act already, and there was a report done on the data collected in 2016. So the top 5 reasons were: 1, loss of autonomy. 92% of the people reported this. Less ability to engage in activities was number 2 at 90%. Loss of dignity, 79%. loss of control of bodily functions, 48%, and feelings of being a burden to family, to friends, to paid attendance, whatnot, at 41%. Those are the top 5. Pain and suffering was not in the top 5. Yet every state that tries to go ahead and put through legislation around physician-assisted suicide lists pain and suffering as the reason to do it. The data does not support this. And if you notice, all 5 of the things on this slide are things that are intrinsic to disability. These are all things that Centers for Independent Living deal with every day. Loss of autonomy, loss of engagement in everyday activities, loss of dignity, loss of control of body functions, and feelings of being a burden. So go ahead, Katie. So we have some societal pressures here and some ableism around these top 5. So let's talk about them. The first is economic. Health insurers rarely cover complex or sophisticated treatments, medications, and supplies. Lots of people get denied. I don't know about you, but it's a full-time job for me to deal with my health insurance company. But in states where the legislation has gone through, many of these insurers do cover the lethal prescription amongst their other prescriptions at a small copay. So I will tell you that when I had my cancer in 2013, sorry, my one in 2014, they did not cover the chemotherapy I needed. And I had to fight and I had to use a different chemotherapy that was not successful, had several months of issues regarding that. You can see how the stress around that can lead to snap decisions about quality of life and whether I want to continue with that. That is artificial and inappropriate. And we shouldn't be using legislation to end life when legislation to fix this is a better option. The second piece of this economically is the loss of a job by the individual themselves and or the caregiver that can result in household financial strain. So that's also a big one. If you have to choose between taking care of your loved one who may or may not have a short time to live and putting food on the table, how do you make those decisions? And that can lead, again, to inappropriate decisions. Katie? We also have some internalized ableism here. We have to look at how disability interacts with suicidal ideation. I know for me, when I had first had loss of function, it made me very depressed. Because I had been taught that, oh, if I lose my independence, I'm not able to do what I did before. My life is not as worthy as it was. This is true for people whose disabilities progress. It also comes up for those who have sustained traumatic injuries. So we need to look at the interplay of this and when people are asking to end their lives and whether the injection of Centers for Independent Living, peer support, information and referral, independent living skills can change someone's outlook on life. So if we can advance the slide. Along with this, so let's talk about this, the myth of choice. This bill, the myth here is that the bill gives people with disabilities a choice by decriminalizing the doctor in this. The fact is that the bill prevents crisis intervention services that is afforded to other people who say they want to harm themselves. On the random street, if you come across somebody who's saying they want to harm themselves, societal reaction to this is to call 911, get police involved, get emergency services involved, call a crisis intervention hotline, any of those things. This bill is suggesting that instead of mandating crisis intervention services for the person who tells a doctor, I want to harm myself, instead it says, oh, get a psychiatric evaluation to make sure the person understands what the medication will do. It does not say anything about providing for crisis intervention services. It does not provide money for such. A lot of us have health insurance plans that does not cover mental health in any way, shape, or form. This certainly does not provide for that at all. And it doesn't provide medical providers any information about the Centers for Independent Living. So how many of our doctors would refer to Centers for Independent Living if they knew that CILs exist to help people adjust to life with disability? Go ahead, Katie. So this myth of choice, the core services of Centers for Independent Living, this information and referral is key. Information, we're talking about informed choice. Without accurate information, decision-making is much more difficult. Let's take an easy example here. If you're told that for lunch you can have hamburger and fries or macaroni and cheese, it's kind of impossible for you to choose pizza. Go ahead, Katie. Having our own pizza. As disabled people, we're often told that we have one choice or we can do another thing, but we're not always given the full range of choices that are available. So what I have on this slide are 4 of the 5 core services. I didn't put transition and diversion on here, but all these 4 core services which impact how we might make a decision about physician-assisted suicide. For more than 30 years, Centers for Independent Living have understood the value and the benefit of these core services in successful adjustment to disability, whether it's a disability that is progressing, whether it's a traumatic event that has brought up disability in its place, or whether it just is the aging process in general. Is Centers for Independent Living, which are set aside by Congress to do these services, this is why. And so physician-assisted suicide legislation actually undermines what we do. Go ahead, Katie. So let's talk about health disparities for a second here. People with disabilities traditionally have less access to quality healthcare. It could be a lack of belief in the person with a disability. I know if I go to my doctor and I talk about a symptom, the first thing they say is, well, it could be because of your Bloom syndrome, which most of them don't understand. And they don't even investigate further, whether that's about treatment or just writing it off. People with disabilities are often expected to endure more pain than the average person, and so therefore it's okay that we're reporting pain. That comes up a lot. Lack of accessibility. How many of us have difficulty getting into certain specialist offices or getting onto an exam table because things are not accessible in the office? Also communication access. How many of us have access to accurate information, our charts, things like that in alternative formats? I know I certainly struggle with that pretty much on a daily basis. Lack of transportation. If it takes us a while to coordinate transportation and an appointment, we're losing valuable time and possibly losing function while this process of time happens. Also, lack of financial resources and health insurance can throw a monkey wrench into when and how we get access to care. Go ahead, Katie. So something that's come up a lot this year and honestly should have come up a lot well before now, but it's on the table now. So we need to make sure that we're putting this as far forward as it needs to be. And that is for those of us who exist at the intersections of other minority groups, race, ethnicity, the language that we speak, gender, sexual identity. All of these factors, unfortunately, have health disparities in and of themselves that this system unfortunately still gives us. When we add disability to that, because people with disabilities exist throughout all of these other categories, we're doubling up on the health disparities, which makes it all the more important to have more information and more support out there. And I think it's imperative on our Centers for Independent Living to be doing this. Go ahead, Katie. So this lack of information and even misinformation in Maryland is really important. We saw last session that Compassion & Choices, what used to be called the Hemlock Society, targeted certain minority communities for misinformation. It was pointed out by a colleague on the national level at Not Dead Yet, Anita Cameron, when she came in and helped testify on behalf of the anti-physician assisted suicide position, that there were several leaders of the Black community in attendance that had been approached by Compassion and Choices and unfortunately had a lot of misinformation about the bill. I know for my own sake, so I'm a member of the Jewish community, I'm an observant member, and last session it was brought to our attention that several rabbis, several leaders of the community had been approached by Compassion and Choices about the myth of choice and compassion for people with disabilities and how could they possibly be harming people with disabilities by promoting the anti-physician assisted suicide position, which again was misinformation, and there's a lot of work that we have to do. So Katie, go ahead and advance that for me. Okay, so how do we counter this? We talk about the issue as a disability rights issue. We outreach to those around us, friends, family, medical providers, communities. We educate them on this and we advocate on this. This can be working with legislators, but it can also be working with your neighbor who has no idea what we're actually up against. Go ahead. So opportunities to get involved. First of all, you can always contact me, and if you can't get directly to me, contact your SIL, they know how to reach me. So how do we do this? We phone, we fax, we email our legislators, we schedule virtual visits with legislators, we write op-eds for our local newspapers. All of these things and so much more, I am ready, willing, and able to help out with. And letting your local Center for Independent Living know that you want to be involved. I can help with talking points. I can help you formulate things. Feel free, just let me know. Go ahead, Katie. So at the end of this presentation, which is available to any of us on the call, has references of where this information, where the statistics has come from, if you want to advance that, Katie. This last slide here also has from Not Dead Yet, which is the national organization working against physician-assisted suicide. It has a list of national disability rights organizations that have come out in previous years with statements against these bills, including the one in Maryland. So if anyone has any questions about each one, you can go to their website. It's hyperlinked on the slide. I'm not sure if that'll come through or not. But if you have trouble reaching them, feel free to let me know and I can help out with that as well. Okay, I think that's it. I know I just threw a tremendous amount of information at people. I'm obviously available for questions.
Feel free to use the chat or unmute your microphone if you have questions. I'll be monitoring the chat. Oops, sorry, go ahead.
This is Chiffon. I have a question.
Yes, go ahead, Chiffon.
Okay. Have you ever know of anyone who they're body abled, but let's say they have a child that's severely disabled? Have you had anyone wanting to have a physician give them a lethal injection because they're thinking they're so disabled they're not going to have a life?
So this is Sheryl. So have I been approached by parents who believe that their severely disabled child is quote unquote suffering? Yes, I'm pretty sure that Centers for Independent Living over time have had this as well. And that's, you know, that's an interplay between the parent and the Centers for Independent Living and mental health services for the parent as well as for the child. You know, that's what we do as Centers for Independent Living, is to make sure that all of the services are available to everyone who's eligible for them. And that includes family members helping with an adjustment to the disability of their child.
Thank you.
And this is Sheryl, Katie, or someone, if you can read. I see flashing. I'm going to assume that's chat stuff, but I can't read it.
Yeah, so someone asked if they could get a copy of this. Two people asked about a copy of the presentation. I put in there the PowerPoint as well as a PDF, and didn't have a chance to finish the text-only document. But if you do need that, I can get that to you as well.
Yeah, this is Sheryl. I have a text-only thing that I did an outline out of. It's not in slide format, but I can get that to you since I used it. Katie, you don't have to do that.
Okay, great. Thank you.
Katie, Lori Elenoff has her hand up.
Oh, yes. I'm sorry. I didn't see you, Lori. Go ahead.
Hi, thank you for your excellent presentation. And I'm wondering, is there any particular legislators or committees that you think that we should contact in Annapolis regarding this, with talking points from you?
This is Sheryl. So I am participating. Oh, if everybody who's not talking could put yourself on mute so we don't get the feedback. Thanks. Thank you. So I'm participating in a statewide call with our partners tonight that should give us more information in Maryland. We know off the top that we will be doing some advocacy in Obie Patterson's area and also in Mr. Sidner's area. So one of those is close to me, Baltimore City. I think that might be Image Center's territory, and I believe that Obie Patterson is in yours, Sarah, is in Independence now.
I have to, yeah, pretty sure he's Prince George's, as I recall.
Yeah, so this is Sheryl. So I can get that information out once I know. There's been a little bit of change because we had someone step down just last week, which changes committee assignments. So we might have to wait another week or two before we really know our largest strategy. We have certain things. We have op-eds that are already planned and going in, but yeah, we'll have more after tonight probably.
Well, and I would just add, Lori, that I think one of the things that that the group will probably be looking for when the time comes is for people to testify. I know that that's been something that you know, there have been a few disability groups who've gone to, but we definitely don't have as much in numbers as we would like to have at those. So if that's something that people are interested in doing, either providing written or verbal testimony, I think that's going to be something that's going to be needed.
This is Sheryl. Katie, that's actually a really interesting point. We're not sure how it's going to go this year because things are going to be virtual right now. And so the way that they have the virtual hearings right now, and this bill is not included because it hasn't dropped yet, but it looks like they're only taking expert testimony like verbally right now, which could change. We don't know. But having your story to tell and to get that into your legislator is never a bad thing. So helping to craft that, whether you tape an audio file or a video, or whether you write it out, I'm happy to help out.
Okay, so Sheryl Gottlieb said there's going to be a limit on the number of people who can provide verbal testimony this year. Written is unlimited. And I know tomorrow the ARC Maryland is having a Sarah found a I forgot what it was called, but you know, like a 45-minute talk 2 times, one at 8 in the morning and one at like 7 at night, about kind of how you can get your voice heard this year during legislative session. And I can go ahead and drop that link in the chat.
Katie, is that you had to identify which chapter of the ARC you were involved with, and so
I just made one up.
I didn't register because I was like, really? Are they going to check my membership? You know, but I think if somebody can attend, it would be great to hear what they share, and then maybe we want to use, you know, part of an IM session to share that information as well.
Now,
This is Sheryl. So actually, there was a question on last week's session about maybe we can get someone in to help us understand that. And I was in touch with Lisa Belcastro's office in between, and they said, set it up, whatever you want on your agenda, we'll do it. So we just got to do it. I think I sent an email to the SIL directors on that.
Now, it's been my experience with legislators that there's a big sort of religious thing going on whereby they're kind of anti this bill. What have you found in terms of the folks in Annapolis, what they feel about it? I know it's come up, year after year, but I mean, it seems like when I go to talk to people, they say, hey, I'm against that, like automatically, because it's a religious thing. But so I really didn't know how much interest there was in the bill being passed at this point.
This is Sheryl. It's been tied in the last couple of sessions. It's split right down the middle. In my opinion, as having been targeted by a doctor for physician-assisted suicide in the past, it's far too close. And something that as people with disabilities, we need to understand how our rights might be infringed upon and make our voices the loudest there, because it's about us, people with disabilities.
Any other questions?
This is Francie Gilman. I was wondering, Sheryl, if you could tell, you said you had a story. Would it be appropriate, would it be possible for you to tell your story?
Yeah, this is Sheryl. Sorry, I was just trying to make sure that we had time for everything. So I have Bloom syndrome, which is very rare. I was not expected to live past 2 and then past 6 and then 10 and who knows what after that. I just turned 45 2 weeks ago. So here I am. I wasn't expected to walk, to talk, to amount to much. My parents were told that because I was first born, that they should put me in a facility because I won't amount to anything cognitively. They were still young, they could have other kids. That was back in the 70s when that happened to many of us with disabilities. My parents decided to bring me home, but they didn't have any support for that. And so they just pushed me to do the best that I could. And thankfully, they tried really hard. I was very lucky in that sense. But along with my condition, it's progressive. It will be eventually terminal. And it is cancer causing. So at this point, I've had 12 cancers. Several of these cancers I've had to go in for treatment. And one of them I was in for extensive chemotherapy, which in and of itself was dangerous for me. And one of the sessions while I was under partial sedation, I was sort of semi-conscious. I don't have friends or family. Well, I have lots of friends. I didn't have any family who was with me in the hospital. I never do. And so as I'm hooked up to my chemotherapy and the sedation meds during treatment, the head psychiatrist at Johns Hopkins walks in, who I knew from previous experiences, and said to me, we can just turn off the chemotherapy, knowing that I wouldn't live more than a week or two without the chemotherapy at that point. Or we could just turn up your pain meds. You're 37 pounds. It doesn't take much to turn this up. Now in Maryland, keep in mind, physician-assisted suicide was not legal. It wasn't then, and it still isn't. But that's what she was suggesting to me. She's like, you don't have to do this. You can just let go. And with as much energy, conscious energy as I had, I pushed her out the door, kicking and screaming. And she turned to me at the doorway and she's like, I don't understand why you would want to live like this in and out of hospitals all the time. And I couldn't really answer her then, but my answer now is it's 7 years later, 8 years later. And I fought very hard for my life. And although I didn't think at that moment, like there have been plenty of times where I've wanted to put my head in the sand and just give up on it all. True. And if a doctor gets to me or a family member gets to me at that moment, I could very well have a very different answer. But the big worry with this legislation is if that were to happen, there's no going back. You can't take back a statement saying, I want this to end when the end is death. You can't take that back. And so when you're depressed or in the midst of treatment where rational thinking is difficult or not there, that's not the time that you need to be confronted with this. You need mental health services, crisis intervention services, centers for independent living to help you understand the long-term consequences of a SNAP decision. Like it shouldn't be a SNAP decision. I could have very easily and had my life ended that day. And if physician-assisted suicide would have been legal in Maryland at that point, she could very well have done it, even if I would have said no. There was no one else in that room.
I think that story is like really a powerful testimony to, the issues that this kind of legislation has. And every time I hear Sheryl tell that story, I don't know how many years in a row it's been, but it's just shocking to me that even without a law, these kinds of things happen, and putting power into a law will just make it even more prevalent.
And what I'm really struck by is the results of that survey about why people want to do this. Because I automatically assumed in my mind that it was terrible pain. Someone's in terrible pain, and, but I mean that's what people automatically think. So thank you so much for sharing that. That's really significant.
It's absolutely true. And I'm not going to say that pain doesn't come up. Of course it does. But honestly, when pain is coming up, we also need to look at health disparities in the system. Is people's pain being acknowledged? Is it being seen as accurate? I've seen health disparities across races where individuals in the Black community have said over and over to me that, it's stated that doctors think that they can handle more pain than the average person. And so there's a lot of factors that go into this, and we need to make sure that things are equitable. We can't just be legislating the way out is death when we're ignoring health disparity issues across races, across any other category. And I think that's the real issue. We cannot bury this, and we cannot use people with disabilities as the bottom line for that.
I wanted to quickly go over some of the things that were in the chat. So Sheryl Gottlieb recommends emailing your delegates and senators. The format is first name dot last name at house.state.md.us or first name dot last name at senate.md.us. She says they don't always agree, but she's gotten quick responses. Also, if you don't know who your elected officials are, there's a website you can go to, mdelect.net. If that is difficult for you to do, or you need assistance doing that, I think your local Center for Independent Living would be more than happy to help you with that. It's important to know who your legislators are, not just for this issue if you want to make contacts, but I always direct people who are having issues that there is no fix for to their legislator to make sure that the legislators know that, this is a problem and maybe they can put legislation together to impact that. And then someone from my staff, I don't know who, said, this information and story brings to light the importance of continuing to fight ableism in healthcare and elsewhere. Happy to advocate via calls and letters when that guidance comes through.
Excellent. I don't know who you are, but feel free to identify yourselves. Thanks.
Do we have any other questions for Sheryl?
Hi, this is from ARI. That was me who left a comment. I didn't realize I was signed in with our account.
Okay, since people are not hopping on all at once, I want to again thank Sheryl. Sheryl, thank you. Little known fact, Sheryl's a member of the ARI board. So I get to, a new member, I get to work with her more often now, which is exciting. And Sheryl really brings this, her arguments are solid, I think. And you did a great job, Sheryl, thank you. So I guess I will open it up now to any announcements people have, people from the SILs or other community members or private citizens.
Can anybody hear me?
Yes.
Okay, all right. I was trying to, sorry, this is Audrey Sellers from ARI. I was trying to ask a question earlier, but for some reason my microphone wasn't working. So Sheryl, I have one more question for you, if that's okay. So, you know, you and I have a lot of, differences, but we also are people who have both, grown up with developmental disabilities, that were visible. And sometimes, it surprises me because the condition I have, CMT, is usually not fatal. But some of my family members, when talking about the able-bodied family members who haven't grown up with this in their families on my dad's side, have said, why would you want to have kids? Why would you want to put somebody through what you've gone through? Which is kind of, along the same lines of, thinking that a life, a disabled life is a life not worth living. And I've heard people, able-bodied parents or able-minded, however you want to say it, non-disabled parents, say the same thing about their kids who are not related to me. So what do you say to parents who say those kinds of things? How do you get them to understand that, these are lives worth living?
So this is Sheryl, and that's a fantastic question, Audrey. For those who couldn't see, I was nodding along with Audrey here, because I've heard it before, I've seen it before, and to be honest, if you ask my mother whether she would have chosen to terminate my brother's pregnancy, who's younger than I am, had the genetics come out positive with Bloom syndrome like they did with me, she will walk out of the room. She cannot answer that even 45 years later, even seeing what my life has been and understanding what I have done with my life over the last 30 years. So it's not an easy topic. What I tend to do is I start with where they're at. That's being stated out of a position of fear. And it's influenced by all of society, right? It took me a long time to come to this because I used to blame parents for this, but they're reacting to an environment that they're in. And I try to work with them where they're at. I try to help them understand just around the edges of things, of some of the silver linings and some of the beautiful moments that they've seen, and help them over time. It's not a one-off. This is not a one-time conversation. And that's why Centers for Independent Living are so helpful, because these are long-term conversations. These are long-term goals. Peer mentorship, if these parents can see others with similar disabilities who are older, who have had more experience, if they can talk to other parents who have worked through these things, that's everything that we do as part of Centers for Independent Living. And as the founder facilitator for Blooms Connect, which is the international support group for people with my condition, that's one of the reasons I started the organization, is so that parents of these young kids all over the world can see that I can have a job, I live on my own, I drive, so that they can see beyond that fear, that there is another choice, that there is something else beyond that. So it's just little by little introducing more and more information and support, and helping them understand where they're at with their fear and what that fear is coming from, and helping empower them to be proactive in ensuring that their child can have the best of those opportunities, can have the full range of opportunities, and not to let that fear sort of box them into single-minded thinking.
Right. I feel like there's so much a parent can do, to influence how their child's life ends up going or their experiences, if they have a developmental disability. Anyway, thank you so much.
Another question, Sheryl, is it okay to share this presentation with out-of-state organizations?
Yes and no. This is Sheryl. Feel free to share, but I really want to caution that some of those slides in there that mention compassion and choices don't always wear their identity on their shirt sleeves. So while they know that we oppose them as Centers for Independent Living, it's probably a good idea to cut out those slides or to not share slides outside of a teaching role. Feel free to ask me if I can do a presentation, or ask anyone, the Centers for Independent Living, if we can do presentations. I know I'm available to do them. Not Dead Yet does presentations. We're happy to help you out. We're happy to support you in doing your own presentations on this if you're interested. I can certainly help you formulate that. We just want to be a little bit careful about how we talk about the issues. So let me know if I can help in any way.
Okay. So community announcements, anyone?
Hi, this is Joan Romanath from ARI, and I just wanted to mention last week when we were talking about resolutions, my resolution was to continue to help people to get out of nursing facilities. And on Thursday, we were notified that 18 people came to the top of the waiting list for Howard County mainstream voucher. So if I'm not on these calls a whole lot in the future, I'm going to be pretty busy, but it's pretty cool and it's a good busy and it's good trouble. So thank you.
Go for it, Joan.
And
that's awesome.
yeah, it's awesome news. I would say that if you see a waiting list outside of the county that you're living in, go ahead and apply for it if you're not opposed to living in that county, because all those 18 people are Anne Arundel County residents who applied for a Howard County voucher.
Absolutely.
So. All right. Okay.
I just want you to know, Sheryl, you talked a lot about, well, I could talk about this at the end if we have time. I could talk about that at the end if we have time. Is there anything else that you'd like to share with us? Because everything's been awesome. So anything else you want to tell us, we want to hear.
This is Sheryl. I'm happy to talk with folks offline. I know we're at the end of our time. I can talk forever. This is a fatal flaw of my own. I am 4'3" and about 48 pounds, but my mouth is my largest organ. Please don't let me run away with it.
Sheryl makes me laugh. Heather, from the Image Center, you had an announcement.
Yep, I don't see Crystal, and I'm not sure Shannon is on the call from Independence Now, but this Friday is Live and Thrive Maryland, which I'm totally not qualified to discuss, but I know that it's the third Fridays. And so if you want information, it's for anybody living with a disability, particularly people who are in facilities, just a way to connect and talk to each other and get information. If you want to know about it, contact the Image Center or contact Independence Now for the information to log in.
Thank you, Heather, for always keeping us on our toes. Right, anyone else? This is your last offer to speak now or forever hold your peace, at least for 2 weeks. As I mentioned, next week we are not having IAM, so take a vacation day, do some service in honor of Dr. Martin Luther King Jr. Day.
Were you going to announce the session on the 25th, or do you want me to?
You go right ahead, Sarah.
So the next IAM session, which is Monday, January 25th, since we won't be here next week, and the speakers are, and Heather's going to send it out, I think, early so that we get a chance for folks to know about it in advance, but 2 end of life issues. This session was requested actually by someone on my staff that it's an important issue. So there's going to be a speaker from the Maryland Insurance Administration to speak about life insurance and end of life planning. And then there's going to be a person from hospice who's going to talk about advanced directives and that sort of paperwork that can be good to let all of your desires be known in advance and have them on file so that others know what your choices are. Very much in line with some of what we talked about today. So that's the session on January 25th. And then I believe that Michael Dalto is going to speak about some legislation in regards to caregivers working in the community that are not, something about their tax identifying information and that has not served people well. So he's going to be on to speak about that.
And then we'll return in February with some cheery topics.
I know we've already got February 1st lined up. Josh Basil will be back. He spoke previously, but he's working on I think an app for identifying service stations and service areas that are accessible. So to get ready for road tripping season in the spring,
Then
right?
the session after that, Duke Morrow, who joined us today from Michigan. We will not say anything about Duke's and my family's difference in supporting of football teams at the college level. That creates bad vibes, but Duke is going to speak some about medical ethics. We're still trying to work out the exact details of the session, but we're looking forward to his expertise in the area of how people with intersections of many different types are involved in medical trials and that sort of thing. So,
Which they play tonight, by the way, Sarah.
Ohio State?
Yes, they do.
Oh.
It's
Yeah.
the Ohio State, Sarah.
It's my dad's team, so I don't really follow, but I did have to, sort of let Duke know that I was sending him a new sweatshirt the last time we were on a call together. So.
All right. Okay, everyone. Well, go forth. Have a great, is today only Monday? It's the longest Monday. Have a great week. And we will see you back here in 2 weeks, 2 p.m. If you have legislative issues that you want to talk about, go ahead and email us. Let us know. We'll give you 5 minutes per issue. And, I saw Abe on here, so I should mention, please, if you're able to donate $1, $5, $10, you can help us keep this program going. It is support from kind people like you that makes I Am possible. Please be generous. All right, everyone, have a great week.
Thank you.
Thank you.